Glad to have you all here, and especially seeing a variety of faces, a lot of students. So glad to see that as well. This is the Future of Diabetes Prevention, Treatment, and Policy. This is part of the Tammy Bray Health Leadership and Innovation event. So there's been a lot going on yesterday and a lot more today. We'll talk about that. Yeah, our honored guest, number one. And with that being said, I'm going to step aside pretty quickly to introduce our guest speaker. But if you're not familiar with myself or my colleague, Dr. Matt Robinson, my name is Sean Newsom. We're going to be moderating the event. There's going to be opportunity for your questions. So we're going to get things started. But if you have something you really want to ask, we will step out of the way for you to ask those questions. There's going to be microphones going around, and we've got Zoom folks, I believe, which thankfully we don't have to monitor. So flag us down if needed, Carrie. With that, I'll step out of the way and introduce our guest, which is Robin Richardson. If you are not already aware from one of the other events, he is a senior vice president at Moda Health. He is also a graduate and alumni fellow of Oregon State University, and immediately relevant to the topic we're going to talk about today, he is a board member of the American Diabetes Association. Now, before we actually dip into the talk or the session on diabetes, Robin actually asked to speak about some news some of us may not have heard of this morning, but has a lot of impact on the folks in the room. So
yeah, well, thank you. Can everybody hear me? Okay. Well, welcome and good morning. Thank you for being here. Yesterday, when I was doing the actual lecture portion of the Tammy Bray lecture, Providence Health Plan, or the Providence Health System, announced that they were discontinuing their Providence Health Plan effective 12/31. That's significant. And the reason it's significant is they have about 500,000 lives that are covered in Oregon, and about 10 to 12,000 that are covered in Washington. But a lot of those are employees here at Oregon State, because they had about 70 to 80,000 lives of the Public Employee Benefit Board. There's three carriers that serve the Public Employee Benefit Board. It's Kaiser, Moda, and Providence. Providence had the largest share of the population at about 80,000. Then there was Kaiser and Moda. Each had about 30,000 each. That's significant. That benefit will go away January 1, 2026. It has a lot of impact also on the market, and it's not good for the market. You would think as a competitor we'd be celebrating. No, it's not good for the market at all. First of all, lots of people are losing their jobs, and then lots of people are losing their health care. For example, Providence had about 85,000 Medicare Advantage lives. So where are those people going to go? A lot of health insurance plans have been fleeing the Medicare Advantage market because the losses are significant, because the federal government has kept cutting reimbursement to providers. They did about a 30% cut. They're going to do another 30% cut. That's significant. And so where are people going to go for their Medicare coverage? So there will be more to come on that, but I thought I should at least talk about for a minute, because it was news yesterday, and it's going to be news for the rest of the year, because a lot of people are going to try to figure out where to go, whether it's small groups, large groups, Medicare Advantage, Medicaid. They have a Medicaid population in the Portland metro area. Where do those people go? Moda can't handle all those people, and we don't want to handle. Blue Cross can't handle all those people, they don't want to. There's lots of risk associated with that. And so I just thought I should bring that up and let you all know, and there will be more to come about it. It's going to be in the news a lot today and the next couple of days. So I just thought I'd let you know.
I appreciate that. And I suspect we all have a lot of questions after that announcement, maybe not all of which we're going to be able to answer today. So
could ask them later.
Yeah, I'm going to do the awkward pivot now to go back to diabetes for a moment. And so if folks in the room know anything about Matt Robinson and I, this is the work that we do. We're deeply tied into type 2 diabetes and how we can prevent and help minimize the consequences of that disease. But diabetes is much bigger than that. So if you'll forgive me if I'm stealing any thunder, I've got to name a few things for everyone in the room. So number one is over 40 million Americans, or about 12% of the population, actually currently lives with diabetes. This is not a small issue. This is not an isolated issue. Perhaps even more alarming in my own mind is 1 in 3 US adults has prediabetes. These are folks who are at increased risk for type 2 diabetes and numerous other chronic diseases. And if you're not impressed by those numbers in an alarming way, this costs us more than $400 billion a year annually in the United States. So this is a major issue, not only with morbidity and mortality, but also economically, thinking about how we manage care for individuals. So we have a lot of reasons to care about diabetes, but before we focus on the future, I'm curious if you could help us understand why this issue is meaningful to you.
Oh, that's great. Thank you. To put into context, I've been a volunteer for the American Diabetes Association since 2000. I was local in the Portland metro area state board chair. I was national board chair of the American Diabetes Association in 2016. They've asked me to come back on the board 3 different times, and so this last time was just a few years ago, and so I was secretary treasurer of the national board, national organization last year, and I'm on the board. I'm not sure how long. I have a lot to do on my plate, but so I've been a volunteer for a long time, and the story about that is Moda was the sponsor of a gala they had in the Portland metro area, and I was brand new to the company at the time. And I didn't sit at the company's table. I was invited by somebody else to go. And so my CEO, who was here yesterday, he called me into his office the following Monday and he said, "You are now in charge of whatever we're going to do with the American Diabetes Association from now on. It's your decision." That is how I got involved. I mean, literally, that is how I got involved. Now, I'll turn this into a personal issue. I am Native American. I'm a member of the Cherokee Nation. My family's last name is Horntassel, and I wear a copper bracelet. Copper was the metal of the Cherokees, and it has our family's last name in the Cherokee syllabary. But being Native American is highly, highly disposed to having type 2 diabetes. And so in my family, my grandfather had it and died. My uncle had it, had horrible amputations from diabetes. My mother died of diabetes. My aunt died of diabetes. All my native side of the family had type 2 diabetes. So it's a personal issue as well. I'm at risk for type 2 diabetes, and I monitor my A1C regularly. I've always been on the border, 5.9, 6. But I was just saying that I had my A1C taken a couple months ago, 5.2. My doctors sent me notes saying congratulations, because that's unusual for somebody like me that's already has 2 strikes against him with genetics to be able to do that. So, and we were also talking at the beginning, when I first got involved with diabetes, I didn't think I knew anybody with diabetes. People don't talk about it. You don't wear a sign that says I have diabetes. You don't tell people that you have diabetes. I didn't think I knew anybody. And then when I got involved, it was amazing how many people I knew that had diabetes. It's a horrible disease. It's terrible. And the impact, strokes, heart disease, all kidney failure, all of those things are related to diabetes. And the statistics say in Oregon, it's the 8th leading cause of death. That's not right. Because you know what? Most death certificates, diabetes is not listed as the cause. It's heart attack, something else that was caused by diabetes, but it's not listed as the cause of death.
Well, I think a big challenge amidst that, you mentioned we don't know many people walking around, even though they're there. I try to encourage some of my students. I'm lecturing on diabetes this week. We discovered and cloned and produced insulin 100 years ago, and we think we solved it. And we're really good at managing diabetes so that patients can live happy, healthy, normal lives. And yet this is just an underlying current. So can you touch on a little bit more as to, we're talking about treatments and policy considerations. We had big discoveries. We produced insulin, and yet now we're doing like some subtle tweaks and some little bit changes. So can you just kind of speak to some encouragement of where are we starting to go with some of these treatments of chronic condition like diabetes?
That's a significant question, and I'll try to navigate, I think, where it makes sense. First of all, type 1 and type 2 diabetes are dramatically different, as you both know. Type 1 is really an autoimmune disease. So it's similar to like lupus, rheumatoid arthritis. I'll talk about that a little bit more. Type 2 is different than that. Your body becomes non-sensitive to insulin, and it doesn't respond to insulin. But type 2 also comes with a stigma. And part of the reason we don't know people with diabetes is it comes with a stigma. Oh, you're overweight. You eat too much. You shouldn't be eating that. You're going to get diabetes, or you have diabetes. So there's already a stigma associated. If you just lost weight, your diabetes would go away. Yeah, no, it's not true at all. And then you also have economic causes. So lower income individuals are more susceptible to type 2 diabetes than higher income. Why? Because of the diet. That is a cause, but it's not, just cutting sugars out isn't going to cure diabetes. And so there's an economic issue. You also have a health equity issue in areas. So Eastern Oregon is a good example. There are no endocrinologists in Eastern Oregon. So if you want to see an endocrinologist, you've got to go to Boise, Portland, Seattle, maybe Spokane. And that's if you can get in to see one. Because often, even in the metro area, if you want to see an endocrinologist, it may take 6 months or more to see an endocrinologist. So you have primary care providers who are treating people with diabetes who aren't trained to treat people with diabetes. And so that's another issue. Are you being treated properly? And then also, as we've learned, type 2 diabetes has about a 20% misdiagnosis rate. So about 20% of people with diabetes are misdiagnosed as type 2 when they're really type 1.5. I would say there's kind of a 1.5 instead of just a 1. And so they're being treated inappropriately as well. They should probably be on insulin. They're being treated with metformin and other things like that, which are really old drugs. And they may not ever find that out. That's a problem. So we have all of that surrounding this in context. Now to get to your main point, nothing's happened since insulin. Nothing. It's just gotten better. And insulin's become unaffordable. I mean, there had to be some steps taken to make insulin affordable. I mean, insulin's such an old drug. It should be sold for, very small amounts of money. And all of a sudden, insulin prices went up to over $100 a vial. People can't afford insulin. Now, the federal government took some action for Medicare, but the rest of the market isn't impacted by that necessarily. So we have an insulin affordability issue where people are rationing insulin, deciding where to use them. But nothing's happened. It's still an old drug. And we've got to do better than that. Now, every year in June, the American Diabetes Association has a very large scientific sessions that this year's in New Orleans, and it's a worldwide session. People come from all over the world, and researchers will often save their new breakthroughs to be announced at this session. So it's in the first week, I think, of June, maybe the second week of June. So if you look in the newspapers about the second week in June, third week, you'll see all kinds of new advances in diabetes that are talked about. And it gives you a reason why they save them until the scientific sessions. All that stuff is embargoed. But it was about 3 years ago at the scientific sessions. It's the first time I heard the word cure. I've heard we may have the potential to cure, but I heard the word cure. And they actually had some studies that were curative. Some of them, I talked a little bit about this yesterday, but not in that context. Some of them are related to stem cells. And it's not artificial pancreases or anything like that. They've tried those and they work, but not well, and they're not the solution. It's about finding a solution to have your body really heal itself, because the body does have that capability. And being an autoimmune disease, your body is attacking itself. So your body is killing the beta cells. Your body is attacking itself. So how do we prevent the body from attacking itself? That's where a lot of the new research is headed. Can we stop that? And then therefore we might be able to have a cure. And they've been showing some cures. And I'm really anxious to see this year what tests have been done, what clinical trials have been done to see a cure. So when I hear the word cure, I actually believe we're 3 to 5 years, maybe 7 years off from really having something that does show that it could be a cure. That's encouraging. And all the years I've been there, I'd never heard the word cure. I'd always heard, well, we've got an artificial pancreas that makes it better. We've got this, it makes it better. But I never heard cure.
Yeah, that's incredibly encouraging. And I hope a number of the students in here are hearing the multifaceted approach. We had considerations of diet, there's exercise considerations, there's basic molecular stem cell research. Well, what hope would you plant with some of the students that are in the room? It's a daunting task. Where do some of them even begin? Can you give them a little bit of hope as to say, here's a direction?
So one of the things, I also mentioned this yesterday, the medical community and the health insurance community is too focused on the end and not on the beginning. And that was one of my themes yesterday. That, think about it, we don't get involved in the system. You don't go to your doctor until you're along the progress of the disease. We've got to focus more on the beginning. We need early diagnosis. We need early treatment. You know, there is a drug out, Sanofi, I believe, that delays the onset of type 1 diabetes by about 3 years. But if you're not diagnosed early, what good is that? You know, most people are diagnosed when they go to the emergency room because they had some kind of event, which could be deadly too. And this drug will prevent it if you're diagnosed early. So how do we start looking at early diagnosis? And that's one of the keys, because if you do that, you can get that drug and you can delay the onset for about 3 years. One of the things that I have in front of me, it relates to the conversation yesterday about getting in front of things. So this little box, Moda acquired a controlling interest in a rapid diagnostics company about a year ago. And they have rapid tests, 10 minutes or less, saliva or finger prick, and inexpensive also, for preeclampsia, type 1, type 2 diabetes, rheumatoid arthritis, lupus, and multiple sclerosis. For type 1 diabetes, because it's an autoimmune disease, and same as lupus and MS, we can identify with this test, it's a little cartridge. You just put a sample of saliva or fingerprint blood drop in it, and you put it in this box, it will give you a numerical reading. So it's quantitative rather than just qualitative. And it can tell you where you are on a diabetes spectrum. Are you early on it, or are you, even though you may not have symptoms? Same thing for rheumatoid arthritis. It can tell you whether you have rheumatoid arthritis before you even have symptoms. And so that can be preventative in a way. And it has European FDA approval, so it's being sold in Europe today. And some of the trials, so this is where I'm getting to your answer, some of the trials are screening young people for type 1 diabetes. If we can screen young people more for type 1 diabetes, then we can get ahead of it, because you've got a drug then that delays it for 3 years. And, you know, 3 years, what did I just say? 3 years might be in the range for a cure. So that's encouraging as well. And so that would be what I would say to give encouragement to all of us, that there is a possibility that we're getting closer to a cure. We can potentially screen early and prevent the deadly effects and get on the drug that may prevent it for 3 years.
That's impressive. I hope for some of the students that there's little ideas like, oh, I could push into this a little bit more. That plants a seed.
If you're not aware, Matt and I do research involving one of the predominant classes of drugs used for type 2 diabetes called SGLT2 inhibitors. So with that disclosure right away, because I don't want to be too drug focused, some of you may have opened your phone or whatever it is this morning and realized that there was a press release from Eli Lilly. And so there's a lot of interest regarding, just broadly speaking, GLP-1 receptor agonists, right? These are the medications that folks are using to lose weight. And, we were talking about the idea of, yes, folks can lose weight. There's some things we don't know about long-term consequences, et cetera. But for context, that data that was released this morning is that folks are able to lose on the highest dose of these medications more than bariatric surgery. And on the lower end of these medications, patients are losing about 20 to 25% of body mass, which is remarkable. At the high end, it's closer to 40%, which is, it's mind numbing for me to even think about that. So with that as a little bit of a backdrop, what do you see as the future of medications? Because we talked about a cure, perhaps as it relates to type 1, but as we spoke about briefly, is a cure is perhaps unlikely for the complex and multifactorial nature of type 2 diabetes. So what do you see as the future of medication as it relates to type 2?
Going back to the scientific sessions, it was several years ago when GLP-1s were first, the research was out for GLP-1s. And then it wasn't long after that it was GLP-2s. So we knew that the GLP-1s were out, and now this is the start of the GLP-2s, which were even more powerful. And I know this research is being done on 3s as well. And it's where does it go? Now, the challenge is that these drugs are phenomenal in terms of losing weight. These drugs are phenomenal in terms of dropping your A1C as well. They've become popular though for weight loss drugs, and you can go online and buy off-label versions of these drugs. It's created a supply demand for people with diabetes and for people who need this. It's a big problem. In fact, the federal government allowed compounding of some of these drugs to happen when there was a shortage of some of these drugs. The challenge is these drugs are also really, really expensive. They're about $1,000 a month. They may start coming down because there's a number of them, but they're $1,000 a month. That is really unaffordable. And the demand for them is extreme. All the large, whether it's the Public Employees Benefit Board, all large groups are looking at this. They want to figure out how to cover it. But the cost that it would add to insurance premiums is just unattainable, unsustainable. The cost has to go down. And I think the cost will go down, but until the cost goes down, these drugs won't be widely available to do what they're really good at. That's a problem. And they don't need to be that expensive, but that's the traditional way where manufacturers increase prices for new drugs coming out because of the development costs or whatever, and then the price will eventually come down. It needs to come down. It needs to come down soon. That's part of the challenge. Or these drugs would be out, and they do work on people with type 2 diabetes. They help because obesity, no matter what the cause, is a large part of the cause of type 2 diabetes. But there's also very thin people that have type 2 diabetes as well. So it's not just obesity. But if you think of all the health care issues that come with obesity, there's a lot of cost savings that would happen around just by reducing obesity, which these drugs would do, in addition to reducing the cost of diabetes. So there's a lot of hope, there's a lot of potential, but it's got to be affordable. This is one area where it's just not affordable yet.
If possible, I'd like to pivot from that. You talked yesterday about innovation And you're talking now about front end of healthcare. How can we help prevent early detection, things along those lines? I think I would get in trouble if I didn't mention AI at some point in this conversation. And I'm really curious what you see as the future use of AI or other innovations as it relates to care and management, particularly as it relates to diabetes, but also perhaps drug discovery, et cetera. There's lots of potential, but where do you see it going?
I'll give you a real world example of that. And in this rapid diagnostics company that we acquired a controlling interest in, one of the things that they did is they were able to develop disease signatures for diseases like type 1 diabetes, type 2 diabetes, rheumatoid arthritis. They're not just a single marker, they're a complete signature of a lot of proteins and things like that. And it took our chief science officer about 5 years to develop his first disease signature. We challenged him last year. We want a complete signature. This is about fall. Complete signature on rheumatoid arthritis, lupus, and MS. Can you do that? Yes. You know how long it took him? 3 months because of AI. That is the possibilities of AI. Now, one of the things we talked about yesterday is AI is not the solution to all of our problems. AI is a tool, and AI needs to be used as a tool. It is not the cure. It is not, it's dependent on data, how good the data is. It's depending on people who know how to use it. One of the things I talked about yesterday was we need to reskill clinicians and health executives on AI and how to use AI. They don't know how to use AI. And so AI is being used in a whole variety of ways, some good, some bad, and that has an impact. But I think AI can help in data, drug discovery, just like that. One of the things we've thought about is a lot of pharmaceutical manufacturers have, because the GLP-1s have been in existence for a long, long time. These are not brand new drugs. They've been around. They were on the shelf, and they were considered poor diabetes drugs at the time. So, but now look at them. So there, a lot of pharmaceutical companies have drugs on the shelf that didn't work for whatever reason or didn't pass the trial. AI could look at all of those drugs that are on the shelf and look at what uses could they be for today that were overlooked before. So that's another opportunity with AI. But a lot of the administrative functions, helping with clinical decisions, all those kinds of things are all potential uses of AI. For example, even within the federal government pays what's called a risk adjustment on the Affordable Care Act individuals, and you keep track of the risk of your members. We would have to go through thousands and thousands of charts individually to find the risk. We have an AI program that now does that in days instead of months to do that. There's a lot of opportunity in health, but we have to be very careful. And one of the things I mentioned yesterday was we also need to focus on digital ethics. You know, we let technology go for a while and we don't pay attention to ethics. And we really need to focus on ethics as we're discovering what are the new uses. And we're going to have a problem too. So think about this. Providers are going to use AI to how to get their treatment approved by an insurance company, the prior authorization. How do I get it more easily approved? They're trying to figure out how do I answer all the questions? Well, insurance companies are going to use AI to prevent the providers from getting it approved. So you've got AI bots competing against each other. We can't do that. And that'll happen in every industry. You can't have AI being used as a tool for you and AI being used as a tool for me, and we're just fighting because the answer will be nothing. So that's one of the things that we have to be cautious about. Now, one of the things that I would say about this, early diagnosis is a real important thing in all of this. And I also think there will be some new technology and things that we haven't seen before. You know, I mentioned stem cells, and I will also mention that we have taken a controlling interest in two stem cell companies, one in Houston and one in Mexico City. The sources of the stem cells in Houston are from fat tissue, and the sources of the stem cells in Mexico City are from dental pulp from shed baby teeth. And we believe that the science has shown that the ones from shed baby teeth, because of where they're developed in the womb, have more neurologic properties than the ones from the fat tissue. And this is another example of the body healing itself. We've seen, again, studies of mesenchymal stem cells being effective in curing diabetes. So I think there's a lot of opportunity beyond traditional drug treatment, or even in combination with traditional drug treatment, that might offer some hope for the future. One of the things that we're looking at is stem cells combined with a pharmaceutical for certain diseases. We think it could reduce the side effects in addition to increasing the efficacy of a drug. Now, one of the things that this stupid little box does also, it can show the efficacy of a pharmaceutical if we have a disease signature for that disease.
Yeah.
So it can quantitatively show whether that pharmaceutical had any impact on that disease signature or what. How do we know if a drug works or not? In most cases, well, if it's a blood pressure drug, you can quantitatively show it. Insulin, you can quantitatively show it, but how do you know that other pharmaceuticals work in treating type 2 diabetes? You have to wait 3 months for your hemoglobin A1C, and what if it did the drug work or not, or what caused the improvement or not? Those are all new technologies that are coming along that I think will impact treatment.
Yeah, just thinking about
This is free flow.
yeah, no, it's super interesting, fascinating.
You had no
Measurements.
idea what I was going to say.
No idea there. But I'm looking. We're thinking about future of treatment, right? And we think about care teams, and you mentioned the idea of there's limited number of people. And in the hospital setting, we're moving towards care groups with physician's assistants, different levels of nursing staff, things like that. Can you touch on maybe where the role of the data scientist fits into that? I mean, will we have a care team that includes
Did you
an
listen
IT
to
person?
my talk yesterday? Because
I think you touch on that a little bit more.
I did talk about this yesterday a bit. We've got to look at new models of care teams. Our healthcare system is disconnected. I don't care what people say. It is totally disconnected. And one of the disconnects is data. One of the disconnects is care teams. People think that a care team is, oh, well, it's whoever was in the room when you're being treated. No, it's not. The care team needs to be much bigger. It needs to involve payers. It needs to involve data scientists. It needs to involve much more than care teams are today, because data scientists are looking at who are the people that are at risk? Who should we be identifying? Who should we be going after? You know, we don't do that. It's done episodically. Maybe the insurance company looks at their high-risk people. Maybe a clinic looks at their high-risk people, but nobody's looking at them together. The same thing is true when people are in the hospital. You know, we need patient navigators to help people. Where do I go? I have diabetes. Where do I go? One of the most distressing things for families and individuals is when you're diagnosed with diabetes, it's a shock, first of all. Well, what do I do? Where do I go? Who do I talk to? We don't have resources. People think we have care teams. We don't have care teams that direct people. And I was using this example yesterday. In the hospital, we spend more time getting the patient out of the hospital, focusing on getting them out of the hospital, and we do nothing to help them. What happens when you're out? Then what do you do? Who do I see? Well, I'm on a diabetes medication in the hospital. What do I do? It's different than what my physician had prescribed. So do I take the one I have at home? Do I take the one that was given to me? You know what happens oftentimes? They take both. And then we have a bad outcome. So there's lots of that in terms of, we've got to improve our care teams. We've got to improve the communication. Even electronic medical records are disconnected. I shared an example yesterday. We've got to really look at healthcare in a different way, in a true team. The other thing I'll say is we're not minting any new endocrinologists. We're not educating even a lot more primary care providers. So what do we do? How do we, because the population's aging, how do we deal with this demand for healthcare that we can't keep up with now? So one of the things I talked about, this is not pandering because it's the College of Health, but one of the most disconnected parts, underutilized parts of our healthcare system is our public health workforce. They're in every county, they're in all the communities, and they are not connected to the mainstream medical system at all. One of the reasons is because of reimbursement. They don't get reimbursed for their services. We've got to change that. Think about how many public health employees are out in our world today. What would that do to our workforce? That would greatly expand our workforce. We have to also look at, though, expanding the scope of what they do. We have to look expanding the scope of what nurses do, of what pharmacists do. That's how we're going to meet this challenge. And that will improve treatment for everybody, including people with diabetes. We've got to train primary care providers, as I said, in Eastern Oregon to treat people with diabetes. But we need to expand their scope of practice. We need to expand the scope of practice for nurses and public health employees.
Actually, I'm really glad that you went there because I could feel extension and policy folks breathing down my neck saying, stop talking about the drugs. Let's hear about some other things. So I'm actually want to make sure we leave time for folks to ask their own questions too. So if you've got those, maybe we'll start walking around or asking for some on Zoom. We've got plenty more. Matt and I can do this all day. But with that in mind, I'm really, focusing on the future and innovation. And you're talking about how could we integrate different individuals across, for example, in the state of Oregon, in the care process. How do we start to tackle some of the disparities in access to healthcare? How do we tackle some of the disparities in disease prevalence and how it's cared for?
That it's on.
Okay,
Okay, there it is.
If we took your little mic and put it right here, it's helpful.
There? Okay. We have some of the brightest minds in healthcare here in Oregon. And we've been fortunate that they just kind of rise up. And we kind of take it for granted that they just rise up. I use Tammy as an example yesterday, Governor Kitzhaber as an example that they've done incredible things. We're not leveraging those people today. We're not learning their experience. We have people who are healthcare leaders that are coming up through the ranks and really could be phenomenal in this. This is going to, maybe I need to step back. Problems are solved not because of some great solution that somebody came up with. Problems are solved because somebody took leadership and solved the problem through leadership. It's not a single act. You have to have a lot of people involved in it. And a lot of people don't step up when they should step up and when they can step up. And they're afraid to step up because there's no encouragement. How do I learn? What if I step into something and I don't know? I don't know what to do and where am I going to go? These problems are going to be solved by leadership. And think about this. I used this as an example yesterday. Governor Kitzhaber in 2012 was facing a hundreds of millions of dollar budget deficit in the Medicaid program. They were going to cut provider reimbursement by 40%. They were going to decimate the eligibility rules of Medicaid. And he went back to Washington, D.C. with a harebrained idea. He was asking him for $2 billion, and he was proposing a concept that had never been used or tried ever before, the CCO concept. And he got the $2 billion, and he got the CCO concept implemented, not himself, but it had to be implemented everywhere throughout the state. Is the problem we're talking about bigger than that problem? I would argue probably not. It can be solved, but it takes leadership to solve it. And that's what we've got to start talking about all together, because everybody in their own silo is going to solve this problem in their own silo. These problems aren't going to be solved in silos. They're going to be solved collectively. And we've got to start talking to each other. I think that's one of the reasons why Debbie invited me to be here today. We've got to talk to each other. Here I am, an insurance company executive, and I'm talking to students. I mean, that wouldn't have happened 5 or 10 years ago. Oh, insurance. But we want to get in front of the disease. We want to get in front of the workforce. We have to, or we're all going to suffer. And if we just sit in our individual chairs, it's not going to be solved. We have to have leadership. So we need to take advantage of the leadership we already have in this state and put them in contact with our new emerging leaders and talk about these issues. The only way they're going to be solved is talking about it, not by, oh, well, I think this is right and I'm going to try this. They have to, this is a high priority. We need to deal with it. And that's how you're going to expand the scope of practice. But payment has to follow. And if you don't have the payers, so community health workers, that was Tammy's idea. We developed a community health worker training program. And then again, another wild idea. And we were using agricultural extension offices to do some of the training because they wanted to change the trajectory of the agricultural extension offices. So we developed all these community health workers. Does it work? You know why it works? Because we got 3 billing codes developed for it. So they can bill individually for their services and be paid for that. That's what's needed for public health. And if we start doing things like that, but if you don't have the payers involved in it, not going to be paid for it. If you don't have other people involved in it, data scientists, we're not going to learn what works or what doesn't work. In fact, one of the things I said yesterday, we do things like value-based payments, global budgets. You know what? There's no data, there's no research on it. We're just doing it because it seems to work. I don't know when it's going to quit working. And then what do we do? That's the importance of having this team looking at these issues all together.
Oh, maybe before we jump into some open questions, an encouragement I was just thinking about. We're filled with a lot of students in the room right now. So just a little audience participation. If you are a student right now, just raise your hand. Okay, quick look around. These are students who aren't receiving credit for being here, don't really need to be here, and yet they're listening to this and planting seeds. And a number of them, who's graduating in a couple of weeks? Yeah. These are some future leaders. So it's really encouraging. So thanks to the students for being here.
They are the leaders, the future leaders. You didn't have to be here. You volunteered to be here. Leadership is just about raising your hand and stepping forward when you don't need to do it. And that is demonstrated by all of you that are here today. Because a lot of people, I'll say one thing, a lot of people ask, how do I become a leader? We get that question all the time. How do I become a leader? And the example I use is when you look at a problem and you say, I might be able to do that differently, or I could learn something to do that differently, or I think it could be done different. You know what? It doesn't matter whether it's the right idea or not. It's the fact that you looked at it, you cared enough to look at it different. That's the sign when you can be a leader, because then that says, I'm ready to be a leader. Now, you're not going to be the CEO or the president of the university right off the bat. Leadership is formed over time. Leadership is formed by attending something like this, by looking at a problem, by stepping forward and saying, I can do this. And over time, your leadership skills are developed. I'm not the leader I was 20 years ago or 30 years ago. And I started out as a student just like you. And I blindly stepped into a leadership position, and it was one of the best things I ever did. I can't believe I was selected. But it wasn't because I was the best. It was because I stepped forward and others didn't.
Speaking of stepping forward, this is your opportunity to ask questions. Matt and I have had a great opportunity up here. We've still got about 15 minutes. So if folks have those questions, now's your time.
That's another problem in healthcare. We all use too many acronyms, way too many acronyms. CCO is a coordinated care organization, and it was again a model idea that was developed by Governor Kitzhaber at the time. It's there's a lot of things to it, but basically you are responsible for all of the care of individuals that are assigned to your CCO. And in our case, and all the CCO's case, we were responsible for medical, dental, behavioral health, and non-emergent transportation. So anything associated with all those things is our responsibility. We are a CCO in rural Eastern Oregon, 12 counties east of the Cascade. There's only 18 counties east of the Cascade. The counties we're not in are Deschutes, Jefferson, and Crook around Bend. We're not in Klamath County, and we're not in Hood River and Wasco County on the Gorge. We are everything else east of the Cascades, from the California border to the Washington border to the Idaho border. Very rural areas, 12 counties, 70,000 square miles, 10 rural hospitals, and a real lack of specialist providers and things. So that's what a CCO is. And it's a model, and it's not just a fee-for-service model. It's a model that we're given a global budget. So that means we're given a fixed amount of money to serve patients during a given period of time. If we exceed that amount of money, it comes out of our pocket. If we save money under that, we get to redistribute it back to providers in the communities. And I will say that since 2012, we have redistributed $400 million back to providers and communities in rural Eastern Oregon. A lot of the services we do drug treatment in jails. We have some food as medicine initiatives. We pay primary care providers more than commercial payers pay primary care providers. We don't get any extra money for it. We were able to do it because of the savings that we had by everybody operating together, everybody being on the same page. So it is a true partnership. The hospitals are our partners. Providers are our partners. And when I say partnership, it really is not just we have a contract with them. We are partners. We make decisions collectively. I remember when we were first developing the CCO, I spent probably 6 months over in Eastern Oregon going hospital to hospital. I got thrown out of a couple one politely because I'm from Portland. I'm from an insurance company, and I represent Medicaid. 3 strikes. But I also told our CEO that if we couldn't get the hospitals as partners, we shouldn't do it, because 60% of the dollar still goes through the hospital. And if you ignore 60% of the dollar, you're not going to be successful. So I went hospital to hospital and talking to them. And one of the things I said, and it's about trust, I said, if something goes wrong, we're going to call timeout and we're going to fix it. I'm not going to say, well, I got a contract with you through the end of the year and we'll wait then, because it's one of those things that, oh, well, you got me this year, I'm going to get you next year. We're going to call timeout, we're going to fix it. And we do that. When something doesn't work, we stop and we fix it. That's partnership. So that's what a CCO is.
She can ask.
Thank you. What kind of leadership do you think we need now for the next 10 years that we lack in public health?
I know. Summer. And when we I'd not heard that before, not just among. They only see what's in front of them today. And it's hard to imagine a different world where you can be paid for your services, where you could actually be out taking care of patients, really, and not in your office. That's hard for a lot of people to see. And so you need people who can help others see your vision. And because leaders need other leaders. That's the issue. You have to lead people who sometimes aren't ready to lead or be led, some people who don't want to change, and some people who don't share your vision. Part of a good leader is having people understand your vision and start going along with it. That's the kind of leadership that we need in public health today.
My question has some overlaps with yes. Okay. Policy as graduate student or even the future workforce in public health, maybe the biggest challenge for us would be current policies or current rules. So I'm curious about your strategies, how we can challenge as a leadership, as leaders with policy or rules that we think they needed to be changed. And yeah, I think that's my question to know what is your strategy? Should be flexible or, go forward?
Okay. It centers around policy. And obviously, at some point, you have to have policy support what it is you're doing. But let's take the community health worker as an example. We knew that title didn't exist 5 years before we formed it. It became a dialogue among the CCOs and among the health authority because there was a problem. We have a primary care provider shortage in Eastern Oregon. We're not able to recruit really new providers. So what are we going to do? And so this idea of the community health worker, the state took a lead in developing a curriculum. That's policy. So it has to start somewhere. It could start at the local level, start at the county level. It could start at the health authority level. Oftentimes, these things don't start at a legislative level. And so a lot of people spend a lot of time in the legislative thing. It doesn't mean that you don't need that support, but it doesn't necessarily start there. Things have to start at the ground roots level. And it helps if you have a payer involved in those discussions as well. But it started by a need, then it started by discussions, and then it's looked at in terms of solutions. So yes, you have to have policy support what it is you're doing, but policy doesn't start the ideas. It's a problem that starts the ideas. It's a need that starts the ideas. And like the agri-stress helpline. Are you guys familiar with the agri-stress helpline? It's a suicide prevention line for farm worker, agriculture, forestry workers and things. That was started here. It didn't start in the legislature. Now, it needed legislative approval to get funded, but it started here with an idea. It didn't start at a policy level. That is a great example of or how these things start organically. There's a need, somebody steps up to address the need, and then it starts getting policymakers' attention. And the same thing like the codes for community health workers to be paid, that didn't start at a policy level. That started at our level. Now we had to go to the health authority and get them to accept that. And then eventually they accepted it as a statewide model because there was a need. So I hope that answers your question. Yep.
What,
What do you think about the prospects for future endocrinologists?
That is a tough one. Part of it's payment. Endocrinologists aren't paid at a level of a cardiologist. They're probably one of the more underpaid specialists that exist. And so when students are choosing their area of specialty in medical school, you just are leaving with several $100,000 in debt. What are you looking at? You want to make a difference. So it's not that it's all about money, but you want to make a difference. Well, I can make a difference in some other specialty that I get paid more. And it's the same thing true with primary care. It's why we don't have a lot of students going into primary care today. It's that we've got to, this is a whole payment reimbursement discussion that has to happen in our world collectively, because I think there's been real big disparities that are preventing people from going into certain specialties. Rheumatologists are another example. They're not highly compensated like some others. We need to look at this differently. And part of the problem we're having right now too is the federal government is reducing the amount of money that professional students can borrow to go to professional schools. And they left nursing out as a profession. So what do you think is going to happen with our nursing school graduates? It's going to go down. And being able to borrow less money is going to reduce the people going into health professional schools. So we've got a number of problems associated with this, but I would say I'm not encouraged right now for the next several years for endocrinologists increasing in number. I think there's a decrease that is going to continue to happen. And think about how long you have to train to get your specialty. I mean, you go to medical school for 4 years, then you go to your specialist and you do something. It's about 10 years. So the endocrinologists that we're looking at today have been 10 years probably in school. So if we look ahead for the next 10 years, there's going to be an issue with that. And that's why we have to have primary care in the interim stepping up and being trained and treating people with diabetes.
how much time?
It's just about GLP-1s because you guys touched on those. It's just somehow they are being abused and somehow people are getting their hands on them. So I guess my question is just like, how do we feel about GLP-1s causing like extreme weight loss, extreme nutrient deficiencies, and how it's promoting like eating disorder culture? Because I feel like at the end of the day, it is making people lose weight, but does it actually end up being healthy for them? Because I feel like in some ways, yes, they are losing weight, but they're not necessarily healthy.
I mean, that is easy to answer. No, obviously that's a very complicated question. And like the data that we were talking about today, or I brought up, I think it was something like 42% of the individuals in the clinical trial reported something, sorry, the terms I'm going to use here, but nausea, diarrhea, things of the, and it's, I watched something from CNBC this morning where the primary news anchor did a double take and said, "Did you say 42%?" And I was like, "Thank you. At least keying in on that. And what are the consequences of if we have people who are taking these medications that from a health perspective don't quite frankly need them?" So it's a very complicated issue. And I think these are things that people are trying to tackle, trying to address from like to whom should we be prescribing these medications? To what extent should compounding be regulated? It's a very good question and one that's very challenging to answer.
That's a good question.
Yeah, very good question. Well, with that being said, it is 11 o'clock. Do I have my time right? Yeah, we're actually just past. So really briefly, I want to, of course, thank Tammy Bray, of course, our leadership team, Carrie Fisher for organizing. Thank you so much. Our audience, our honored guest, Robin Richardson, thank you so much for being here. We've got a little bit of a break right now. We've got lunch, a light lunch at 11:30, and another 12 p.m. session on rural health, innovation, and access to care. So hopefully we'll see you there for that session as well. Thank you all so much.
Thank you all.